Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
All right, welcome, bitches, to the Transformation Nurse Academy podcast. My name is Kevin, and we're going to be transforming one nurse at a time. So this week, we're going to be talking about the genitourinary system, right? So I made another comprehensive study guide, and you don't have to download it, but if you want to, go to transformationnurseacademy.com, go to the shop. It's free as for now. All of my study guides that I created are free. This study guide is an introduction to the genitourinary system. We cover the urinary system. We cover the reproductive system. We cover the integrations of the functions. We talk about the kidneys, the ureters, the bladder, the urethra. We talk about the male genitalia, the female genitalia, hormone regulations. And then I cover in the book or the study guide, I cover history taking, symptoms analysis, physical examination, and diagnostic procedures. I also have a section on special considerations for the pediatric and geriatric assessments in geriatric patients. We talk about some common genitourinary disorders and issues such as kidney disorders, bladder and urethral disorders, female genital disorders, and GU disorders related to trauma. And then I cover some sections about nursing implications of the GU assessment, patient preparation, education, fluid management, preventing and managing complications, nursing care, diuretics, antibiotics, so medications that are covered in there, and then other special considerations for trauma. So, managing renal trauma, managing bladder ruptures, urethral injuries, emergency surgical interventions. And then I give you 5 case scenarios and then all the terms and stuff. So it's packed full of stuff. It's free. Go to transformationnurseacademy.com. Download it, save it, share it, because I work hard on this stuff. Give me feedback. You know what I mean? I'm not going to be mad if you don't like something or there's something that maybe I got wrong. I'm a human stuff. But again, welcome to today's episode where we're going to explore the genitourinary system, often abbreviated as the GU system. It's a role that plays a critical part of our body, helps waste elimination and reproduction. My favorite is reproduction because I got fucking 6 kids. Ain't that right, Miss Pat? Miss Pat wants 7 or 8 more, maybe. So whether you're a nurse, a doctor, a healthcare professional, understanding the GU system is very important. All right, because we got to pee, we got to relations, so we can reproduce our offspring. So we're going to dive into the anatomy and physiology of the GU system. Again, in the book that I created there for you, I do talk about the kidneys and stuff. So, the kidneys in the GU system, it comprises of the urinary and reproductive system. It's a complex network responsible for eliminating waste. It helps with fluids and electrolyte balances and reproduction. So the kidneys are vital. They're bean-shaped. They're located in the retroperitoneal space. So don't forget that fancy word, retroperitoneal space. Retro means behind. Peritoneal is here in your abdominal cavity. So retroperitoneal means behind your belly. It's on the side of the spine, just below the rib cage. Each kidney is the size of a fist. Not always, but technically size of a fist. And they weigh approximately 150 grams in most adults. The structures of the kidneys, you got the cortex and the medulla, you got the nephrons, you got the renal pelvis, and the calces. Don't ask me how to say that. Calcyes. Calces. Urine is formed there in the nephrons. It drains into the minor calces, then into the major calces, and finally down into the renal pelvis. The renal pelvis is a funnel-shaped structure that directs the urine into your ureters. And then from the ureters, it goes to your bladder. And from your bladder, it goes out through your urethra, out into your toilet, or into the grass if you're a dude and shit. The function of the kidneys, they filtrate, they reabsorb and secrete. Concentration of the urine, the kidneys regulate the urine concentration based upon the body's hydration status. This is achieved through the countercurrent mechanism called the loop of Henle and the action on ADH, or the antidiuretic hormone, in the collecting ducts. And then they have hormonal functions. The kidney produces erythropoietin, EPO, which stimulates red blood cells production. So one of my first trauma patients that I ever took care of back in 97, 98, I don't remember when it was, some back in the early 90s or late 90s, should I say. He was a football player here locally at a local college. I won't tell you just in case his family's still around. I don't want to hurt their feelings. But he was a big dude. He was probably about 6'8". Maybe not 6'8". He's probably about 6'5", though. He was a big dude. He probably weighed a good, I don't know, 230, 240 pounds. He was probably a linebacker. I don't remember because it's been so long. But what I remember was he would take epoetin because he wanted to increase his red blood cells to help with his recovery time after football practice and after the football games. Problem is he got so much red blood cells it caused him to start having compartment syndrome. And then he had to have a fasciotomy from his thighs all the way down to his calves bilaterally. And he became so infected that the doctors came to him and his family and said, we're going to have to amputate both legs from the waist down. And that's the only way we can save you. And he's like, I'm not doing that. The family says not going to do that. And that was my first patient ever. And so he just decided he didn't want to live anymore because he wasn't going to have legs. So please don't take epoetin to recover and shit. All right. It's not meant for that. But anyway, epoetin, it helps with the red blood cell production and renin, which plays a critical role in blood pressure. You know, it's called the RAS system, the renin-angiotensin-aldosterone system. The kidneys also activate vitamin D, which is essential for calcium homeostasis, right? And then we have the ureters. We talked about the ureters, the bladder. And then we have the bladder, which stores urines. The fancy word for urination is micturition. micturition, micturition. Miss Pat, did you micturate today? So urination is a coordinated process involving both voluntary and involuntary mechanisms. As the bladder fills, the stretch receptors in the bladder wall send signals to the brain, causing a sensation of the need to urinate. So when your bladder stretches, it gets full of pee, there's a signal that goes to your brain that says, hey, I need to take a pee. And then you go and urinate. And then we talked about the urethra. In the book, I write down about the structures of the urethra. There's a female urethra, the male urethra. The male urethra is longer and has 3 sections. The prostatic urethra, which passes through the prostate. The membranous urethra, which passes through the urogenital diaphragm. And then the spongy or penile urethra, which runs through your penis. Yeah, but is it really spongy if my penis is hard? I got to think about that one. Maybe that's why when you got a hard on and stuff, your pee goes everywhere and stuff because it constricts and it shoots out like a rocket. And then women don't understand why we pee on the toilet. And then we're going to talk about then I cover female and male genitalia. You know, the male genitalia, you have the testes, the prostate gland, the penis. Female genitalia, you have the ovaries, the fallopian tubes, and the uterus. And then the vagina. And then I have in there hormonal regulations. I go into depth about the RAS system. Remember the RAS, or the renin-angiotensin-aldosterone system. Its role is in fluid and electrolyte balance. The RAS is a critical hormonal pathway that regulates the blood pressure and fluid balance. When blood pressure drops, the kidneys release renin, which catalyzes the production of angiotensin II. Angiotensin II causes vasoconstriction and stimulates the release of aldosterone from the adrenal glands, which increases sodium and water reabsorption in the kidneys, raising your blood pressure. Right? So clinical relevance, dysregulation of the RAS system can lead to conditions such as hypertension, heart failure, chronic kidney disease. So understanding this system is essential in managing these conditions. So I know that as nurses, you know, we learn about the RAS system in school, but most people just read it. Renin turns into angiotensin 1, angiotensin 1 turns into angiotensin 2, and blah, blah, blah. But you really need to understand, especially if you're in critical care, you're an emergency nurse, you got to understand these systems because you can see it at the bedside when you're giving medications or your patient has high blood pressure or acute kidney injuries of some sort. And then the antidiuretic hormone, this is functions that your GU system makes. The ADH is a role of water absorption. ADH, also known as vasopressin. So sometimes you give vasopressin IV push and stuff in the ICU and the ER. It's produced by the hypothalamus and is released by the posterior pituitary gland. It acts on the kidneys, specific in the kidneys, the collecting ducts, which increasing water reabsorption and concentration of urine. ADH release is stimulated by high blood osmolarity and low blood volume. high blood osmolarity. So if you don't know what high blood osmolarity is, why don't you get a book and read? Like, I had a conversation this morning with one of my students, and I went into the BLS class and I asked people, like, did you read the book before you came to class? And of course, what do people say? They don't read. And people always ask, how do you get so smart? The answer is read a book. That makes sense. So if you want to be a better professional, you want to be an awesome nurse, pick up a book and read. So high blood osmolarity refers to an increased concentration of solutes, such as sodium, glucose, and electrolytes in the blood relative to water. So when you're talking about homeostasis, if you could take a round tube and close off both ends and fill it up as much as you can. 50% is water, 50% is solutes, such as sodium, glucose, other electrolytes. If you have 50-50, then your body's in homeostasis. If you have a high blood osmolarity, high is dry, low is wet. So causes of high blood, and the normal serum osmolarity of a patient's blood is 275 to 295. Normal serum meaning referencing blood, normal serum osmolarity is 275 to 295. High is dry, low is wet. So a high blood serum osmolarity refers to an increased concentration of solutes such as sodium, glucose, other electrolytes in relation to water. This condition can be indicative of dehydration, where there's a loss of water, or other conditions where the solutes become more concentrated. So dehydration, diabetes. When you have diabetes, your cells get sticky with molecules of glucose and everything starts to stick together and your blood osmolarity increases. That's why patients with diabetes are at risk for strokes, heart attacks, PEs, things like that, DVTs. Kidney dysfunction, if the kidneys are not able to properly excrete solutes or retain water, such as in your hemodialysis patients or your dialysis patients in general, they can't get rid of that. So their electrolytes are so high and stuff. So they get concentrated urine, if they even make urine at all. Hypernatremia, this is an excess of sodium in the blood, which directly raises osmolarity. Loss of fluids, such as nausea, vomiting, diarrhea, excessive sweating, can also cause high blood osmolarity. So some of the symptoms: thirst, dry mouth, mucous membranes, confusion, lethargy, weakness. So I talk about this in a class all the time when, I push on the CPR mannequin and I say, what are we trying to do? And everybody says, oh, we're trying to get perfusion to the brain. What does the brain need? Oh, it needs oxygen. Well, you're not wrong, but you're forgetting about all the other shit. Your brain needs glucose to work. It needs sodium and electrolytes to work. So if your electrolytes are off, your glucose is off, your patient's not going to do well mentally or physically. So just keep that in mind, all right? Treatment of hydration, treatment of dehydration, you want to rehydrate with electrolyte fluid, electrolyte balanced fluids, the normal saline, lactated ringers, more specifically 0.9% normal saline. This is something I teach too, is when people talk about normal saline, I always ask, what type of normal saline? Because there's many different types. There's 0.9%. There's 0.45%. There's 0.33%. There's 3%, 7%, 23%. There's so many different types of normal saline that don't just assume that's what the physician is asking for. There's D5 normal saline. There's D5 normal saline with 20 milliequivalents of potassium. So there's many different types of solutions that we can use to help fix this hydration if somebody has serum osmolarity issues. So the kidneys are a central hub in the urinary system located in the rib cage. They filter about 120 to 150 quarts of blood every day. That's crazy, right? The urine contains waste products, excess water, electrolytes, and toxins. The kidneys play a crucial role in filtering all this stuff out, all right? And then the reproductive organs in the GU system differ between men and women. So we talked about that. And the reproductive organs in the male, they got the testes, the vas deferens, and the prostate and the penis. In women, they have the ovaries, fallopian tubes, uterus, and the vagina, where the eggs and the ova, menstruation, and pregnancy happen. So the GU system doesn't function in isolation, though. It works in tandem with other systems, such as the cardiovascular system and the endocrine system. For example, if the kidney function is compromised, cardiovascular issues such as hypertension often follow, as the kidneys play a significant role in the regulation of blood pressure. Urine output is a big one. So if we're assessing patients, we always assess urine output. Accurate monitoring of urine output is one of the most straightforward yet crucial vital signs. But for some reason, people don't like to mess with pee. If you're a damn nurse, you're going to be pissed on, shit on, crapped on, thrown up on. Like, you should get used to it. Just make sure you wear your PPE so it don't go in your mouth and your eyeballs. Oliguria or reduced urine can be a sign of kidney dysfunction, hypovolemia, or some other underlying issues. Anuria, Anuria, and let me go back, oliguria, I know I'm probably not saying that right, Oliguria, or reduced urine output. Anuria, Anuria, or no urine output is even more severe sign that there's some kind of acute renal injury or acute renal failure. You want to look at the urine output. You want to look at the urine color, the clarity, the odor. I don't know how many times I tell people you got to learn to use your damn nose because you can smell things. And when you learn to smell things, like when people are a dialysis patient, I know it sounds kooky, but man, get close to them, touch them, and smell them because you can smell these smells that permeate through their body. And that's this waste that their body can't get rid of. When you're around a patient that maybe hasn't like fully gone into those kind of issues, you start smelling it, you can try to head it off and prevent it from getting worse before it even gets to that stage and stuff. So I'm not joking. Learn to use your smells. You can smell a head bleed. So don't be afraid to start learning to teach your nose how to use these smells. So anyway, you want to look for urine output, color, clarity, odors. Hematuria, Hematuria, hematuria is blood in your urine, can be indicative of trauma, infections, even cancer. A cloudy appearance may suggest infection or the presence of crystals. One condition that people get a lot is gout. You ever heard of gout? Gout is related to uric acid. Like, oh my God, if you've ever had uric acid in your system, it is freaking painful. So gout is a form of inflammatory arthritis caused by the accumulation of uric acid crystals in the joints. Uric acid is a waste product produced by the body that breaks down purines, which are substances found in certain foods and drinks such as red meat, seafood, alcohol, and sugary beverages. So I have gout, and I take medicine. I take allopurinol for it. However, I know it sounds crazy, but I stopped drinking the dark Coke Zero. I used to drink the regular red can Coke Zero. And man, my arms and joints hurt so bad, but I stopped drinking it and moved to Zero 7-Up, and I don't have any more problems. Now, I don't drink that much anymore either, but I do eat a shitload of red meat because I do keto. But when your body produces too much uric acid or fails to eliminate enough of it through the kidneys, the excess uric acid can form sharp needle-like crystals in the joints. And man, that shit hurts. So key points about gout, you have hyperuricemia, hyperuricemi. That means elevated levels of uric acid in the blood. You got to pay attention to your diet. Could cause kidney dysfunctions. Impaired kidney function can reduce the excretion of uric acid, leading to the buildup. Genetics, like my mom has it, my brother has it. I don't know if my dad has it. Miss Pat has it because her dad has it too. Usually signs and symptoms are joint pain, often the big toe, swelling, redness, limited range of motion, and flare-ups. So those are things that could, if you have kidney issues or kidney disorders, you could have that as well. Diagnostic tests that you would use on your patient to check to see their kidney function would be common laboratories like the BUN or the blood urea nitrogen, both and serum creatinine, both of which are indicators of kidney functions. Elevations in these values can point towards acute kidney injury or chronic kidney disease. Urinalysis or UA can provide a wealth of information, such as are the presence of glucose in your urine, is there protein in the urine, which suggests kidney damage. Urine in the glucose can be an indicator of diabetes. Are the white blood cells in your urine, which could be a signs of infection. You can also do renal ultrasounds, CAT scans, and MRIs to get further diagnostic information about your kidneys and your urinary system or your reproductive systems. So when patients are unable to urinate naturally, we go automatically to catheterization. But, catheterization is a big problem in the hospitals with chronic urinary tract infections or CAUTIs. CAUTI stands for catheter-associated urinary tract infection. It's the big one because nurses are still inserting Foleys, but the problem is they're still being taught by some schools to inflate the balloon to check for the balloon's integrity. Stop doing that shit. We stopped that a long time ago. If you inflate the balloon to check for the integrity, the catheter is no longer smooth. If you look at a patient's urethra, it's round, it's pink, it's moist, it's smooth and beautiful. But then when you take that catheter and you inflate the balloon and deflate the balloon, now that urinary catheter is all wrinkledy. And then if I put my wrinkly old catheter into that beautifully smooth urethra, it's going to cause micro tears and trauma as it goes in. And most nurses aren't very good at keeping sterility in their process of putting in catheters. So you're dragging in bacteria that damage urethra. And then when you inflate the balloon, you're shoving those bacteria into the micro tears. So quit doing that shit, Stop causing cardiac. Start checking yourself. Bring a buddy if you need to make sure that you don't break, sterile field and stuff. Because if you have cardiac, we're not going to get paid for it in the hospital. And this is one thing I'm going to work on soon is I'm going to work on a podcast episode on healthcare as a business. I know nurses don't get taught this in school, but we need to start understanding that healthcare is a business. It's not going to change anytime soon. If you want to get paid more, if you want to make a difference, if you want to be heard, you have to understand that this is a business and businesses want to make money. And you need to learn as a nurse how to save money for the organization. And once you start doing that, they're going to start hearing us more. But until then, they're not going to pay attention to us. The urinary system also talks about, it also helps with fluid management, electrolyte balances. We might use diuretics such as furosemide or Lasix, which is often used to increase urine output in patients with fluid overload, such as those with heart failure. However, they must be administered carefully because they can cause dehydration and electrolyte imbalance and compromise kidney function. So what they're saying is if you're that nurse that likes to overload patients because you love to give IV fluids, now you send your patient in to overload, you dilute their system, and now because of that, you want to give them a diuretic to fix your screw up. Now you're going to make them more dehydrated or have electrolyte imbalance, and you're going to cause them to go into acute kidney injury. So if you start looking at your systems and being more methodical about your processes and not just react and start learning to respond, you're not going to cause your patients that kind of damage and stuff. So calm down with your medications. Patient education is essential. You want to educate your patient on the history of kidney stones or kidney injuries, things like that, chronic problems like diabetes, hypertension, and how they affect their system. Other things that you may want to think about when you're assessing your patient and under the GU system, did they have any come into the ED with any blunt trauma? So blunt trauma to the abdomen or the back can cause kidney injuries, can cause kidney lacerations. Car accidents, fall, sport injuries can lead to renal contusions. Here's the problem, though. If your kidney gets bruised or contused and it starts to swell, what is being constricted? Not just renal flow, but also vascular flow. So you got to think about that as well. Just like when you get hit in the chest and your lungs start to swell, everybody goes to respiratory, but remember, your lungs are very vascular. So if your lungs start to swell, you're getting decreased blood flow as well. So same thing when it comes to the kidneys. So nurses should be vigilant for signs of flank pain, abdominal bruising, and hematuria. So abdominal bruising, they call that the Gray-Turner sign. Maybe I did, man. I better look that up because now I'm having a brain fart. The Gray-Turner's sign. I think that's what I call it. There's two signs, the Gray-Turner signs. So Gray-Turner signs is a sign in the back. So Gray-Turner's, Gray, Turner, Gray-Turner sign is a clinical sign of retroperitoneal bleeding or hemorrhage. It is characterized by bruising or discolorization of the skin on the flanks. Gray-Turner sign could be a sign of pancreatitis, abdominal trauma, ruptured aorta, ruptured ectopic pregnancy, retroperitoneal hemorrhage. So Cullen's, Cullen apostrophe S, the term Cullen's sign, Cullen apostrophe S, is umbilical bruising. Periumbilical bruising. Peri just means around. So Cullen's sign refers to bluish or purplish discolorization around the umbilicus, and it indicates the presence of intra-abdominal bleeding. Like the Gray-Turner sign, which is flank bruising, it's often associated with conditions that cause hemorrhage within the abdomen or the retroperitoneal space. Again, acute pancreatitis, ruptured ectopic pregnancy, AAA trauma, things like that. So you want to make sure you pay attention to those different kind of signs, because if you see them, you got to pay attention for your patient. So in the case of a bladder trauma, a ruptured bladder is often seen in pelvic fractures. One of the most key signs is difficulty urinating or visible blood at the urinary meatus. So if you're inspecting the urethra and you see blood at the urinary meatus, that is a contraindication for urinary catheter. You may want to talk to the physician. Maybe they need to have a specialist come in or maybe put in a super pubic catheter or something like that. Penetrating traumas like gunshot wounds, stab wounds can severely damage the kidneys. They can damage the bladder or the reproductive organs. So immediate assessment and stabilization are very critical because hemorrhage is often the greatest concern and the number one cause of death in a trauma patient. You could have acute kidney injury or AKI, which can occur in traumas, especially if there's significant blood loss or shock. In these cases, careful monitoring of the urinary output, the blood pressure, renal functions is essential. Renal perfusion must be restored as quickly as possible because if your kidneys are damaged, they're not getting blood flow and if you don't get blood flow, they're not getting the nutrients it needs to keep their cells alive. All right. So what should you look for? Again, we talked about urine output. Urine output is a key vital sign in assessing the GU system. One of the first signs of the GU system distress is a change in the urinary output. Always correlate changes in urine output with other vital signs. For example, low blood pressure and decreased urine output may be indicative of hypovolemia or some type of shock. Hematuria and abdominal pain. So blood in the urine is a red flag. Blood in the urine is a red flag. That's a nice little pun and shit there. So blood in the urine is a red flag. It may be a sign of trauma, infection, or malignancy. Always investigate hematuria promptly. Don't just say, oh my God, sir, you got blood in your urine, and just ignore it. All right. Abdominal or flank pain, especially when accompanied by these changes in urine output, should be a prompt way for you to start investigating and let somebody know. Sepsis and GU infections. The GU infections like pyelonephritis. Pyelonephritis is a kidney infection. Urosepsis, you got your septic in your urinary system. It can rapidly escalate. I had this happen. I won't say who, so if you listen to this, don't be mad. I won't say your name. But when I first came back to the place I'm working at, my first patient, she was 30-something years old. She had pyelonephritis and DKA. Heart rate was 166. Blood pressure was 187 over 102 or something like that. And they weren't doing anything about it. And I was like, are you not concerned about what you're seeing there? Like the patient was supposed to be a Glasgow 15, but she was like maybe a 12 or 13. She was confused. They told me, oh, her lactic acid is fine. It's only 1.6. Yeah, right now. But what are you going to do if you take your time and don't pay attention to this? Like it can escalate very rapidly. And I'm not a big fluid person, but over my shift, I wound up giving like 10 liters of fluid. And I only got her heart rate from 166 back down to like 110. So you can't just let these things fester because it's going to progress. And once you get to a certain point, you may not get back. Remember, there's 3 stages of shock. Stage 1, stage 2, and stage 3. But once you get to stage 3, you're kind of screwing your patient. And you should have been paying attention back on stage 1 and stage 2. So you got to make sure. So infections, pyelonephritis, your urosepsis. You want to look for fever, chills, flank pain, changes in mental status, especially in older adults where sepsis can be life-threatening. So I know we covered a lot. In today's episode, we covered essential aspects of the GU system from anatomy, trauma interventions. We play some, GU system plays major roles in the waste, regulating fluids, electrolytes, and reproductive health. Let me go back over here. I'm going to pull up a scenario that you can cover. These are one of the scenarios that I put way in the back here. Scenario number 5, managing a patient with bladder incontinence. So Miss Smith, 72-year-old female, is admitted to the hospital for a urinary tract infection. This is very common. That's why I put it in here. She has a history of stress urinary incontinence. What does that mean? Stress urinary incontinence. So stress means you're stressing the shit out of me. Urinary means pee. And incontinence means you can't keep your pee inside your bladder. It just comes out. So stress urinary incontinence is a condition in which the involuntary leakage of urine during activities that increase in intra-abdominal pressure, such as coughing, sneezing, laughing, exercising, or lifting heavy objects. The pressure overcomes the ability of the pelvic floor muscles and the urinary sphincter to maintain control over the bladder, resulting in a leakage of urine. Causes of urinary stress incontinence is weak pelvic floor muscles. Pregnancy, childbirth, aging can weaken the pelvic floor. What can you do to strengthen the pelvic floor? What can you do to strengthen the pelvic floor, Miss Pat? Kegels. Ladies, do your damn Kegels and make your hoo-ha tight so you don't fucking pee when you sneeze. Damage to the sphincter, the urinary sphincter, which controls the release of urine, may become weakened or damaged due to surgery, childbirth, or hormonal changes, like a decrease in estrogen after menopause. Do you have stress urinary incontinence, Miss Pat? You want to confess that now? Do you fucking pee when you cough, sneeze? Oh, shit. I'm stressing Miss Pat out, so she's peeing everywhere when she coughs. Increased abdominal pressure, such as obesity. So if you're heavy, ladies, or men, your big old ponces pushing down on your bladder can cause pressure. Chronic coughing from smoking, asthma can cause this. Heavy lifting can put pressure on the bladder, exacerbating stress incontinence. Hormonal changes, like I said, decreased estrogen levels, especially after menopause, can weaken tissues around the bladder and urethra. Risk factors, unfortunately, women are more likely to experience urinary incontinence, especially after childbirth or menopause. So those are things you got to think about. So diagnosis, physical exam, bladder stress test, and a urodynamic testing. Urodynamic testing tests the measures. This test measures bladder pressure and the function to understand the cause of the incontinence. So those are things you got to think about. So that's one of the case studies I gave you. So let's go back to her. Miss Smith, a 72-year-old lady, is admitted to the hospital for urinary tract infection. She has a history of urinary stress incontinence, which has worsened over the past few months. Miss Smith is embarrassed. Who wouldn't be embarrassed if you're walking and coughing and you fucking leaking and dropping all over the floor? I'd be embarrassed too. But don't be embarrassed, ladies. It's part of life. Do something about it. Anyway, she's embarrassed for her incontinence and avoids social activities due to fear of these accidents. So during the assessment, the nurse conducts a detailed assessment of Miss Smith's incontinence, noting that it primarily occurs during activities that increase abdominal pressure, such as coughing, sneezing, and lifting. Miss Smith uses incontinence pads, but finds them uncomfortable. I know who's going to want to wear your urinary incontinence pads. Your depends. Now, this is one of my biggest pet peeves is nurses, and I don't know if it's a generational thing, if it's a nursing thing. I'm not trying to throw shade at nobody, but stop calling them diapers. I know they're diapers. You know they're diapers, but you're talking to grown-ass people. Grown-ass people don't want to wear diapers. That's why we call them urinary incontinence pads. That's why we call them depends, because they fucking depend on them so they don't pee on themselves. But when you're talking to a grown person and you're talking down to them and you're calling them diapers, it's embarrassing even more so. And they're not going to want to talk to you. So don't be an asshole and call them diapers. All right, so upon a physical examination, the nurse assesses Mrs. Smith's pelvic floor strengthening through a physical exam, noting weak pelvic floor muscles. The nurse also evaluates Mrs. Smith's ability to empty her bladder fully. So if you have weak muscles and you can't push out the urine when you pee, you're going to have this residual urine hanging out in your bladder. And when you have residual urine hanging out your bladder and women have a short urethra, you are at higher risk for urinary tract infections. So what can you do? First, you can teach your patient pelvic floor exercises or Kegels. So the nurse teaches the nurse how to perform Kegels. You squeeze your butt cheeks and your hoo-ha and your ball sack tightly for 5, 10, 15 seconds, let go. Squeeze them together, 5, 10, 15 seconds really tight, let them go. And just keep doing that every day, right? The nurse emphasizes the importance because performing these exercises will help improve incontinence, right? And then bladder training. So you want to start bladder training. I know it sounds crazy, but if your bladder's all weak and it doesn't know what to do, you got to train it. So you can do hourly training. You can do every 2 hours. So it's up to you, but you want to do regular intervals. So you want to initiate bladder training on a regular interval and gradually extend the time to avoid it. So start with maybe every 1 hour, take her to the bathroom. Every 1 hour, take her to the bathroom. Tomorrow, hour and a half. And make sure they do the Kegel exercise. The goal of this is to increase bladder capacity and reduce the frequency of incontinence during the day. Incontinence products that you can discuss, there's different products, discuss with, including more comfortable and discreet options, such as absorbent underwear, right? They're fucking basically, what are those damn diapers called? The pull up, the training, what do they call them? The ones we have for kids that you pull up, the pull ups for kids. Oh, they're called pull ups. Pull ups, I need a little revenue for a shout out for your damn products. They do have pull ups for adults, and they got different colors, different shapes. Again, don't call them diapers. Quit being an asshole to your patient. You're going to be here one day, you young son of a bitches. You're going to be peeing and shitting on yourself, and you're going to regret that you were mean to patients because it's coming. right? Karma's a bitch. So don't be mean to your patients. But, there's different things that you can do. There's barrier creams that you can use to protect your skin, Desitin, things like that. Lifestyle modifications. So lifestyle modifications, try to help them lose weight, reduce caffeine. Like me, I drink a crap load of coffee every day. And what does coffee do? It's a diuretic, makes you pee. Try to avoid anything that irritates the bladder. Make sure that you stay hydrated. But, as a concentrated urine, if you don't stay hydrated because you're drinking a lot of coffee, your electrolyte balance and all that's off, it's going to make your urine and your bloodstream more concentrated. It's going to irritate the bladder and worsen the incontinence. And then psychosocial support. The nurse addresses the emotional impact of incontinence. You got to make sure that you understand that nobody wants to pee on themselves. Because if you're always peeing on yourself, then you stick like pee, then you don't want to be around anybody. So you got to make sure that you help these clients who have urinary incontinence. Provide them support, improve their quality of care, because you're going to be there someday. All right, so I know we talked about a lot. We talked about a lot today. We reviewed anatomy and physiology. Well, we talked about some different trauma issues, some nursing interventions, electrolyte fluid imbalances. It's a lot to cover, so I can't do it in 1 hour. So as a healthcare professional, stay vigilant for the signs and symptoms of the GU distress, which can lead you to have better outcomes for your patients. So if you recognize them early, you're going to have better outcomes. So whether you're managing a simple UTI or a complex trauma case, recognizing signs and symptoms earlier and acting upon them decisively can make all the difference in your patient. All right? So again, I appreciate you guys. I hope you enjoyed this episode. Again, go to transformationnurseacademy.com and download your comprehensive guide. And again, I want to put a shout out to Miss Pat, Ariane, Roberto, Daniel, Claude. We are here at Central Valley Medical. Is where I work full time. We do ACLS, PALS, BLS. We do TNCC, ENPC. And yes, we do follow all the guidelines. My methods of training are very different than most. I follow the rules, but I also use the rules to my advantage as well. So I am a trailblazer when it comes to education. Some people may not like the way I teach. Some people may not like the words that come out of my mouth, but it doesn't mean it's wrong. Just because you don't like it doesn't mean that you have to call people and say that it's wrong or tell them that things are bad. So support us. You can go to www.morethancpr.com or you can go to centralvalleycprclasses.com. We're starting to do the RQI hard code system. So if you're an administrator, if you're a CEO, CNO of a smaller facility and you want to save money as well as improve patient outcomes, as well as save costs and have a better outcome for your nurses, compliance, let us show you how the RQI and hard code system can revolutionize your hospital. We take on the financial burden. We maintain the machines. All you got to do is implement the system. And I love it. I thought I was an awesome nurse until I did the damn RQI machine. And man, it showed me how I needed to improve my skills. So we can all improve skills. So again, thank you for visiting us. Thank you for listening. I hope you enjoyed this episode. Again, my name's Kevin. All right, you people, I love you. Don't forget to visit us. I love you, bitches.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.